But again, welcome. My name is Emma Nolan. I am the Manager of Government Relations and Health Initiatives with the ARC of Pennsylvania. And I want to welcome you to our second of 4 Lunch and Learn topical working series. Today, we're going to be talking about elevating the voices of people with disabilities and their family members and caretakers in healthcare settings. This all stemmed from a project that the ARC of Pennsylvania has been doing over the past couple of years, focusing on COVID-19 healthcare barriers among people with disabilities, as well as creating a really robust set of solutions to try and mitigate some of those barriers to healthcare. We really wanted to focus on calling for disability inclusive healthcare across the state and try and create that set of solutions that really all correlate with disability inclusive healthcare. So what it kind of has looked like over the past couple of years is that we have a COVID-19 health disparities task force, which is made up of a lot of different stakeholders and people who have a lot of insight into this topic and can guide us during our journey. We also have regional community work groups, which are comprised of over 400 individuals across the state, all led by our amazing regional community work group coordinators with our chapters. These individuals ranged from people with lived experience of disability, family members, caretakers, health professionals, all across diverse racial, ethnic, and rural or urban or suburban populations. Of course, we have the ARC of PA admin team as well, and all of our local chapters. And this work wouldn't have been possible without the Pennsylvania Department of Health's funding. So today's focus, we are going to look at 2 of those recommendations in the recommendations report and show some practical things that are already being done across the state in our Lunch and Learn series today. So those recommendations of focus are number 1, which is elevate voice. So involve people with disabilities, their families and caregivers in policymaking and healthcare decisions, as well as recommendation number 9, effectively communicate. Provide information in ways that everyone can understand, such as in plain language, in Braille, and in multiple languages. So today's agenda, after I finish introducing this, we are going to talk a little bit about the ARC of PA's health disparity report and recommendation report before diving deep into our practice panel today and opening up to some whole group discussion. So the first year of that grant has really focused on developing that set of barriers. So again, we spoke to over 400 individuals across the state with really unique perspectives and asked them 2 main questions. The first one being what worked in your area. So what were strengths in your area that led you to be able to receive healthcare services? And then the main question having to do with barriers. What didn't work in your area and made you maybe not receive adequate health care or made it really hard to receive services. So again, the voices that we heard were really unique and diverse. We had diversity by role, again, people with disabilities, caregivers and family members, professionals in both the fields of disability and healthcare. We had intentional outreach to all disability types and all races, ethnicities, and by location as well. And when we gathered all of this information, we were able to organize it by something called a social determinants of health model. And a social determinant of health is anything in the areas or environment that you live, learn, work, play, or worship that influence your health in some way, shape, or form. So the ones that we're going to focus on today have to do with systemic healthcare barriers and social and community context barriers, such as information or cultural linguistic barriers and communication. We also did a sort of listening and recording conversations with some of our participants. And all of these conversations are embedded in our report with really, really neat QR codes that you can scan and hear the experiences of some of our participants. So we're just going to show one of those examples today that really correlates with the message that we want to put out during this Lunch and Learn.
Say that to people become proactive and include people with disabilities in the things that are needed beforehand. You know, getting input from people who have that lived experience, and we can talk about those things, and we can from the get-go design programs and implement systems that really do address the needs of people with diverse disabilities. And unfortunately, I don't care how good intentional people can be without disabilities, you do not have lived experience with disabilities. And therefore, you leave stuff out. And in leaving stuff out, you put people with disabilities' lives in jeopardy to the point where they can die, to the point where they can feel helpless, just like I did.
That is just so powerful, hearing directly from Theo about his experiences and his expertise in this field. So again, that's just one example. We have, I think, 10 of those little videos embedded in our report. So I really urge and want all of you to go to that report. I think it's in the chat by now, and click on those and really listen and learn in that report. Another quote from there is, people with disabilities were struggling, but they had options, and people with disabilities didn't have those same options and access to accurate information. We just didn't get it. Another one of our participants in that video series was Jenny, who is a parent and advocate for a child with autism from Montgomery County, who said that health information is so critical. Any kind of inaccuracy or discrepancy in information could lead to something significant. And I know I touched on that recommendation that we're going to be going over a bit today, but just to give a bit more context of that, this is all about involving people with disabilities, their families and caregivers in policymaking and healthcare decisions. This is our recommendation number 1, and it really shows across the entire report how important this recommendation is. So some examples of what this could look like is individual and systemic healthcare decisions, equitable employment of people with disabilities in leadership positions, listening sessions, panel discussions, participant forums from hospital systems or healthcare systems, and then people with disabilities or family members being on boards and advisory groups to make sure that all of the policies being implemented were discussed with a person with a disability and making sure it's equitable and accessible. The other recommendation we're going to touch on today is provide information in ways that everyone can understand. So what this might look like is timely information in various formats. So Braille, large print, American Sign Language, closed captioning, qualified accurate language interpreters, timely information in plain language as well. So making sure all information presented is clear, concise, accessible, literacy levels, meaningful graphs or images or social stories, alternative text descriptions of images, embedded definitions, as well as communication support. So those social stories or bilingual consultants in healthcare settings to make sure people are receiving information in ways that work for them. So now I'm going to turn it over quickly to Rhonda Beach Tyree, who is our amazing facilitator, to bring us through a couple of resources and practices of what this could look like across the state and across the country.
Thank you, Emma. As Theo said, we heard barriers to elevating voices of individuals with disabilities and their caregivers. We also heard about strengths and practical resources. For example, this tool by the Center for Disease Control and Prevention, the CDC, is a model, become a disability ally in your community and promote inclusion for all. And it uses a simple mnemonic: A, acknowledge and respect individual experiences and abilities. L, learn about different disability types. L, leverage your influence to promote accessibility and inclusion. And Y, yield the floor to people with disabilities to help identify and eliminate barriers. We can all be a part of that kind of engagement. Here's another tool by the National Association of County and City Health Officials. There's a website on the essential elements of local public health. Has lots of articles and resources on disability-specific health equity topics like this one: organizational support to amplify the voices of people with disabilities. There's a handout that we're putting a link to in the chat that has links to tools like these. And there's a lot on how to provide understandable and respectful information in healthcare settings. For example, the NIH, the National Institute of Health's web pages, has plain language tools, resources, trainings, and even contact information for their plain language staff in each of their institutes or centers. You know, the Plain Writing Act of 2010 is federal law that requires the federal government to write documents and forms in simple, easy to understand language. One of the things we heard over and over, especially when there was the interdependence of having a cultural or linguistic challenge, but also perhaps needing to have things communicated in plain language, that healthcare information was not always provided in accessible ways, and how challenging that was. Here's another tool. The National Center on Disability and Journalism has a disability language style guide. Our Temple University Institute of Disabilities has an etiquette style guide, and they're experts on plain language, provide self-study modules and other approaches to thinking about not only disability etiquette, but plain language. And here's a couple of tools. The Philadelphia Coordinated Healthcare, PCHC, they provide assistance to anyone in South and Eastern Pennsylvania who's seeking healthcare information for either themselves, their family members, and their friends with intellectual disabilities and or autism, and have ideas and tips for how especially to access information that's needed. And then getting the care you need, a guide for people with disabilities, is one of many tools that the CDC offers on, the Centers for Medicare and Medicaid offer on empowering individuals with disabilities on how to communicate and work with people in an interactive way to get the care that they need. Communication is so important. And then finally, another example of a tool that has become so important to us, especially in the last few years, is the use of technology. And Temple Institute on Disabilities is doing a lot of work, including weekly online technology training series for how to use technology, which certainly is so applicable to healthcare, but all sorts of aspects of one's life. We're excited to bring you two examples of practitioners in Pennsylvania who are operationalizing, elevating the voices of people with disabilities in their healthcare, and have a lot of experience in effective communication, which is not only about what you communicate, but it is about listening and engaging. It's my honor to introduce Sabra Townsend, who's with us today. She is the Director of Operations at the Jefferson Center for Autism and Neurodiversity, and she's here representing Karen Roseman, who is the licensed clinical social worker and community medicine co-director of Jefferson's for Adults and Beyond Center for Complex Care. Karen has been one of our task force members who is one of the co-authors of the report and recommendations and has worked very collaboratively with this project. And Sabra is mother and parent here, also bringing voice to the experience of someone In the second circle of support to an individual with lived experience, her son, Brandon Hubbard. She's bringing forward his voice virtually to us today, and we're so grateful you're here, Sabra. And then we're also going to hear from Allegheny Valley Hospital. We're going to hear from practitioners who represent occupational therapy and physical therapy. We'll hear from Elaine Brenman, who's an occupational therapist, registered, licensed, certified brain injury specialist, and she's the lead OT for their brain injury rehabilitation unit. And her colleague, Susan Little, who is a PT, a physical therapist, and also certified brain injury specialist. We're delighted you're here. We hope to have a bit of time for question and answer after. And of course, the chat's available if you want to make comments or ask questions as we go along. Sabra, welcome.
Thank you, Rhonda. Pardon me. Thank you, Rhonda. You know, you can introduce us anytime. Thank you so much. That was so nice of you. Thank the ARC of Pennsylvania for having me, Sabra Townsend. And as Rhonda mentioned, Karen Roseman is unable to be here today, but was a critical part of the report that was just referred. Next slide, please. So I'll give a little description of the two centers that are represented today. For adults and beyond, the Center for Complex Care provides primary care to adolescents and adults with complex childhood onset conditions at Jefferson Health, and they're actually located in the Navy Yard, which is pretty much the southernmost tip of Philadelphia. The great plus is that they have free parking. They have a team approach with medical doctor, Dr. Mary M. Stevens, and social work and nursing on site with a team approach. And I, as I mentioned, represent the Jefferson Center for Autism and Neurodiversity. We have a team of developmental behavioral specialists who work with children and their families to assess potential diagnoses and develop personalized care plans that integrate all of the things that happen in the family setting, medical, educational, and therapeutic services. We also consult across not only Jefferson, but also in the community with businesses, other healthcare organizations, and community stakeholders to promote awareness and provide training for neurodiversity and accessibility issues. We have a motto, it's not original to us, but essentially nothing about us without us. So at every step of the way, we consult with people on the spectrum or who have neurodiverse concerns, in addition to having them be a part of our advisory council. Next slide, please. And then the overall mission of Jefferson, that's one of the reasons why we certainly do enjoy working at Jefferson and providing services, because our values are actually on the back of every ID card. Put people first, embrace diversity, be bold, and think differently, and do the right thing. So at the end of the day, that's exactly all of the things that we work toward. Next slide, please. So the current state of affairs, the Americans with Disabilities Act is certainly based on civil rights laws in the United States. It applies to autism and other invisible disabilities, but there actually are not guidelines for invisible disabilities. The Americans with Disabilities Act is focused often on physical disabilities, which is great, but there are also issues that happen that you can't see, and we need to work on getting some guidelines as a part of the Americans with Disabilities Act. So just like a ramp is helpful to someone who travels in a wheelchair, it's also helpful, as you can see, for someone who has a baby stroller, the delivery guy. It's a ramp that helps bridge the gap in terms of services. Next slide, please. So the benefits of embracing diversity, making sure that you're welcoming, that people who may have intellectual disabilities or have neurodiversity may bring different ideas to the table, There's certainly an intrinsic motivation that matters in performance. You have a broad range of people, therefore you have different ways that you present information to them. And we talk about inclusion, and we would like to make sure that services have people belonging, which is an even broader area that you want, the way that you want to include everyone in the services that are being provided. And so if you think that diversity doesn't include disability, you're kind of doing it wrong. We want to make sure that everyone who has a need is able to express the need however they can express it. Next slide, please. So neurodiversity may be a new term to some. It involves processing and communicating a little differently. It's an umbrella term that does include autism, IDD, certain psychiatric diagnoses, neurological problems, and aging. And in fact, anyone with a novel or a stressful medical condition or a significant life stressor. So if you've or know someone who's been, for instance, in a car accident or has had a significant diagnosis, that can create stress and that can create neurodiversity because you think differently. I think of folks who may be going through chemotherapy, or people that may be going through dialysis. It may change how they view the world, how they access information, how they communicate. So that also falls under neurodiversity. Next slide, please. So this is my son, Brandon Hubbard. I'll tell you a little bit about him before we play the clip. And I do have his permission to talk about him. Brandon is now 26. He's on the autism spectrum. He was also born with a very rare condition called prune belly syndrome. And as his mother, I'm going to take off my Jefferson hat and put on my mom hat. He's 26 now, so he is certainly a young adult in this world. And when he was little, because of the complexity of his medical conditions, and then, just for kicks and grins, we got the autism diagnosis. When I would have all of the different meetings, the IEP meetings, the ISP meetings, the early intervention meetings, I had a story that I would tell real quickly, and I'll share with you that, Brandon takes his body with him everywhere he goes. And prune belly syndrome is a connective tissue disorder that affects some of his activities of daily living. But if he was in a kindergarten class or an early intervention class or 5th grade class, his body is right there with him. So whoever is interacting with him has to take all of that. I can't send his arm to the therapist and his left foot to the orthopede, and his right arm over to physical therapy. You get it all. And I say that because one of the things that is helpful in terms of providing medical care, at least that's also offered at for adolescents and beyond, the FAB Center down in the Navy Yard, is a comprehensive approach to care. So there is a way that care can be provided that looks at the whole person, that looks at the whole family, and provides care in that way. So having kind of introduced them that way, if you could play the video, I'd appreciate it. Okay, so who am I? Okay, so what is tomorrow?
My birthday.
And how old will you be?
23.
All right, so can you introduce yourself?
Hello, my name is Brandon.
Slow down.
Hello, my name is Brandon Hubbard. I'm 23 years old. I graduated from Hill Friedman. And my favorite color is red.
And who's your favorite sports team?
Green.
The
Eagles.
spell it.
EAGLES. Eagles.
So that's my Brandon. You may notice that kind of prosody of speech, that kind of sing-songiness. You might not expect that out of a 6'2", kind of handsome African-American young man. You also may have noticed that when he came to discuss his favorite sports team, that he used American Sign Language. Now, I didn't know that he understood American Sign Language. When he was very little, maybe 6 or 7, we would Brandon has sometimes actions and motions that are that he moves his hands a lot. I wonder where he gets it from. But anyway, we were kind of playing, back and forth. I wouldn't call it patty cake, but we were, playing back and forth. But when I really noticed what he was trying to do was get me to do signs, American Sign Language. And for a child at the time who was minimally verbal, I found it absolutely fascinating that someone, and I'd never found out who in his school setting, was teaching him American Sign Language. He understood it very well. So with that, I mentioned that even as we talk about medical care, that you do have to presume competence. You have to make sure that you choose to assume competence in the people that you're interacting with. Next slide, please.
Okay.
This is another example of different ways that people can communicate. A young man who communicates via letterboard, and with patients, you can certainly understand a whole bunch of information that he has to convey. So the takeaway here is that if someone is nonverbal, that does not mean they don't have information that they need to share. Next slide, please. Here's an example of, it's not the clearest picture, but education and engagement. We do visual stories, and this gentleman is holding up a brochure that walks you through a visit to primary care so that you can have a sense of what the visit is going to be before you get there. And the picture on the right is part of a visual story in terms of checking in. That one happened to be with women's health. Next slide, please. And then this is a slide from FAB with the Navy Yard and Dr. Stevens and Karen Roseman. There are teaching opportunities with Pennsylvania Developmental Disabilities Council, providing education to Jefferson. And you all may not know that Einstein is now part of the Jefferson family of hospitals with their medical residency program. And also Jet Philadelphia, expanding education, creating areas of concentration for family medicine residents, and creating a class in the medical school. And again, that speaks to us looking to assist in expanding family medicine doctors so that there will be more physicians, nurse practitioners, medical providers who are aware of the different disabilities. And I mean, that's certainly a plus, because of medical advances and research advances, people are living longer. And that's a wonderful thing. But we also need to expand the amount of medical providers who are available to provide medical care. Next slide, please. And if either Rhonda or someone, Nancy, could give me a high sign in terms of my time, I would appreciate it. Thanks so much. So here are some tips on smooth transition to adult care. If you're caring for, or you are a young adult or a young child, your parents need to look at what their current providers have, asking community members for recommendations, asking the primary care provider for recommendations. And you don't want to have gaps in care, so you want to start that in the early years. It's a transition that you need to start planning for relatively early. So you want to find out about what kind of insurance they accept. Are they accepting new patients? Will there be a wait to be seen? There's often months and months that until you can make an appointment. What is the criterion to be accepted in the practice? Of course, where are they located? What kind of accessibility is available? And do they have a late or a no-show policy? Next slide, please. And so in preparing for your first visit, you might ask your current provider to send information prior to the visit to the new provider, your last visit notes, or that you may have a chart or an electronic system that you can go into to share at that first visit, the vaccine history, a list of current medications, a list of durable medical equipment, copies of power of attorney, all of which I actually have for my Brandon, and I've done that for him. And he has certainly been a part of putting that information together, and contact information for not only any medical specialists, but also any supports coordinators, community providers, mental health providers, behavioral health, school information, nursing, home health agencies, and case managers. I actually have a folder that I pick up that has all of that information, and I keep that updated. I actually made it one of Brandon's favorite colors, which is red. So I see it, it's red, I scoop it up, we go to the doctor. Next slide, please. So here's some first visit questions. What do you want to know about the doctor and the practice and the nurse practitioners in the practice? Have your questions, write them down if you need to. What medical questions do you have? What kind of expectations can you set? What do you need from the healthcare providers? And what is the best way for them to communicate with you? Do you have a friend or a family member you'd like to be present for appointments or have access to the medical information? And does that office have policies about folks that may not be related as a part of the visit? Next slide, please. And so the core differentiators in terms of this approach is that it's lifespan. And this approach for FAB in Navy Yard, and also the Center for Autism and Neurodiversity in our programmatic side of things, these are the core differentiators in both programs. The lifespan, meaning, from birth to death. Multidisciplinary, we try to make sure that all angles are used, all perspectives are used, in addition to the different disciplines. If there's a specialist that's necessary, we try to make those connections. It is certainly multifaceted, and I'll speak for JEFCAM, which stands for the Center for Autism and Neurodiversity, that we look not only into Jefferson, but also out in the community. And I'll give you a quick example of training in Jefferson. We just worked with JeffStat, which are the folks who manage the ambulances and the Metastat, the helicopters. If someone needs to have an urgent transport. And so in training the staff, we make sure that they're aware of all of the possibilities that may come with someone who may be minimally verbal or may have unexpected behaviors. And then, of course, we want to make sure that things are evidence-based. We also, in our programs, have pre and post questionnaires to measure the types of outcomes that come from the trainings that we do, and provide that as evidence. And then advocacy, to make sure that to the extent that we can, the type of services that we're providing can be replicated, not only in the community, but in other medical settings. Next slide, please. So here's an example of FAB down at the Navy Yard. The lovely lady sitting on the lower stool with her arms crossed is Dr. Mary Stevens, and she's the co-director with Karen Roseman of the FAB Center for Complex Care. Next slide, please. Here's an example of a neurodiverse patient. We do have his permission to use this picture, and he just felt like stretching when he was checking in. And he's just a lovely young man who communicates via letterboard. Next slide, please. And so here's a bit of a background. I did mention this in terms of the Center for Autism and Neurodiversity. We also participated, as I mentioned, in the built environment, in making sure that the new building will have not only be accessible, but have certain things in the building that will be helpful to everyone, and specifically to folks with neurodiverse concerns. It's definitely an environment conducive to care. We're also introducing a healthcare resume that the family and the individual can fill out to make sure that medical providers are aware of some of their preferences and needs in terms of their medical appointments. Next slide, please. And of course, building capacity, as I mentioned, with the built environment, we've provided consultation to other providers and how they build their operations. This happens to be a shop when we were consulting at a behavioral health center in the region. I mentioned the health resume. I mentioned the courses across the discipline. And we're working even within Jefferson to make sure that there's a better understanding of all of the needs. Next slide, please. Here's another mnemonic that we use in terms of interactive strategies. So scaffolding and sensory environments. Spark is the mnemonic. Certainly be patient. Just sometimes take a beat, just take a breath. If someone's trying to express something, to give them time. If you have to ask a question again, ask it in a different way. Don't necessarily ask it louder, just ask it in a different way. Attend to the matter at hand, respond and don't react. And there's never too much kindness in the world to make sure that the information that the person is trying to get to you is received and acted upon. Next slide, please. Here's part of the same strategies. This happens to be at the flower show, Philadelphia Flower Show. Be patient, don't judge, respond, don't react, be aware of sensory needs, prepare patients for the visits and exams, use visuals if necessary. Try your best to coordinate care, schedule carefully, consider telehealth. By schedule carefully, and I know scheduling is often a challenge, but perhaps there's a way to have the first appointment in the morning or the last appointment of the day, whichever works well. Involve caretakers thoughtfully. And again, as I mentioned up front, presume competence. Next slide, please. Perfect timing. Thank you. Thank you. Thank you. If you have questions, I'm certainly available via email, saber.townsend@jefferson.edu. I can pop that in the chat. And Karen Roseman did, again, express her regrets for not being able to present, but said that you can certainly reach out if anyone has questions via email, and I will put her email in the chat as well. I don't know if you're taking questions now or at the end, so thank you.
Sabra, this is Rhonda. Thank you so much for what you do. Fellow mother of a young man with autism to mother, I am just so grateful for the work that you're doing. I know one thing you can anticipate is how do we get more information? Go ahead and put your email and then any other key links that you'd like in the chat, and we'll follow up with those. We're going to invite questions after our next speakers. And I'm just so excited they're with us. Elaine and Susan, welcome.
Thank you. So I think we're going to try to share the screen. Bear with me. Oh. Are you able to pull up our slides?
They're up right now.
Okay. Sorry about that.
No worries. We're great.
All right. So I am not seeing our slides.
I'll bet the ones we were seeing were the ones you were trying to show us. We'll go ahead and transition here. Nancy, are you on pulling them up?
I can try again if you were seeing them.
Yeah, I bet that was your screen we saw. Beautiful purple slides.
You want to do this and I'll start talking. I don't have a password. I think we closed it out.
Elaine, I've got them up for you here.
Okay,
Yeah.
all right,
My
perfect.
screen.
Thank you. Sorry about that. That's always my biggest fear.
And it's always less time than it feels like, Elaine. No worries. There you go.
There you
Okay,
are.
all
Thank
right.
you.
So thank you for having us here today. I'm sorry about that little glitch, but I am Elaine Brenneman, an occupational therapist, middle-aged with brown hair, slightly graying. And I'm wearing my gray hospital scrubs. I know we don't have our camera turned on because we are in the hospital where we're working. But we are glad to share with you a little bit about our program, but hopefully also to share some insights that we have learned along the journey. The title of this presentation, For Everyone Born, is in reference to a song that some of you might be familiar with. The song speaks of the need for a place for everyone at the table. And just as Saber was saying, everyone should have a voice. Families, patients, the whole person should have a voice and a space at the table. So the song speaks specifically about shelter, space, a safe place, fairness, a voice, diversity, and freedom for all. You all live and work in the system. You experience disparities and challenges every day. You strive to explore ways to change and better the systems. For that, we appreciate and thank you, both for your work and for the opportunity for us to sit at this table. If you can advance the slide. So I just want to briefly talk a little bit about who we are. We are Allegheny Health Network, and that is a conglomeration of 10 hospitals, many emergency and urgent cares, several therapy clinics, and some preventative medicine programs in the western side of the state, Western PA, where specifically our facility is just outside of Pittsburgh. Sue and I were brought on board about 5 years ago to help develop a brain injury rehabilitation program at one of the local community hospitals within the network. Allegheny Health Network strives to be a leader in healthcare, and as part of that process, the core values that you see on the screen were identified as the basis for all of our programs. I won't go into detail about these, but wanted to speak briefly about the first core value listed. Customer first is our intention in all that we do as a network. When we set out to design the brain injury program, Sue and I were very mindful that the program would be designed with the customer first approach. You can go to the next slide. So at the community level, we are Allegheny Valley Hospital. It's a small community hospital. As I said, it's north of Pittsburgh, and we are part of a bigger network. Our facility is an 17 bed unit within the hospital. We are one of 2 clinics in the area with disease specific certification from the Joint Commission, and the disease specific is brain injury rehabilitation. And as we designed the program, we knew we wanted something that was evidence-based and patient-centered to be our guide and our lead. So as part of that process, you pick guidelines to guide your practice. And we chose specifically the Canadian guidelines because they were very evidence-based and they were patient-centered. And I won't spend a lot of time on the guidelines, but just as an example, some of the guidelines, one of them suggests, immediately upon entry into the rehab program, we should be talking to patients about what their goals are, because really the job of rehab has evolved over the years. It's not what we perceive a goal to be for a patient, but it's really directed by what their goals and what their experiences are. Okay, you can advance to the next slide. And so our mission and vision statement, I don't want to spend a lot of time on those. Again, it's up there so you can read those, but the mission statement I included in the presentation just to stress the importance of a mission and a vision for your organization or program that you stand behind. We spent a lot of time writing our statements, and really honestly, as I think about it as a younger person in my career, when I went to work, I didn't really think about the mission and vision statement, but having had this opportunity to design a program, spent a lot more time thinking about the mission and vision that we wanted to see. And so in short, we wanted to work alongside our patients to promote recovery and to aid with adjustment to injury. And that involved a lot of relationship between us and between the patients. So we couldn't do it on our own. We wanted input from our patients. Brain injury is rarely resolved at the end of rehab. It's a lifelong disease, and therefore up to us to work closely with other professionals, with our patients, with our families, to provide quality support, treatment, and planning for successful reintegration into the home and into the community. We are passionate about what we do. So the first sentence in the vision statement is to realize a community where survivors of brain injury are accepted as capable and valued members. That's our passion. And listening to Saber earlier, that's the passion, right? We want patients to have a voice and to be a part of the community and not to be looked at as different or unusual, but we want them to be a part of the community and accepted as everyone should be. We believe this to be a vision not only for the survivors of brain injury, but all patients who come through our rehab unit. If you haven't already, I encourage you to investigate the mission and vision of your organizations. Ensure that they are patient-centric and challenge your organization to live into that model. So where were we? Oh, can you advance the slide? Sorry. So where were we and where are we now? So in the traditional model, I've been around in rehab for about 30 years. And as a newbie, I entered a system that was very much focused on the medical management of patients who had a disability. Patients were expected to follow the advice of the professionals without question. Goals of care were written with very little input from the patient. At that time, patients had a limited amount of access to medical information. Doctors were viewed as experts, and questioning a treatment decision was unheard of. I was lucky to work in a place that valued input from the patient right from the get-go. And yet, as I look back, I see just how far we've come in the last 30 years. Next slide. So with the advent of the personal computer and increased ability to access the internet, the traditional model started to be challenged. With information more accessible, people read more, investigated more, and questioned more. This change in access to information triggered a change in how we treat patients, how we cared for patients, and how we worked with patients. I should note here that not all information is good information, and that too changed our interactions and treatments in the world of rehab. And just to throw out an example, I had a young man who had a stroke, came to our rehab, and him and his partner were very invested, very knowledgeable, sought out every person they could to give them information on the recovery process. And we talked many times, sometimes explaining why I was using one technique or another, sometimes asking where he wanted to go and what he was expecting out of a treatment, so that we could, again, develop a relationship and work toward meeting his goals, which were to return to teaching. He was a teacher and a principal of a high school in the area, and his goals were to get back to his job. And so we spent a lot of time with that. And just a funny side note, one day he said to me, you know, I want you to know I ordered a book from Amazon on how to treat someone with a stroke, and you're doing okay. So I just, you know, I think patients get information from many places, some of which we know about, some of which we don't. But I think being willing to sit down and talk to patients, to have them comfortable to say, you know, I found this information and I question this, or why are you doing it this way, or why are you doing it that way? Or can we try this? I think it's important for us to be open to hearing what patients are asking and what they're telling and what their goals are. So in the patient-centered model, the focus is on the patient and his and her abilities, preferences, values, and individual needs, whereas prior, the focus was on the disability. For patient-centered model, the focus is on the quality of life. So what is important to, rather than for the patient. And I think the biggest take home is communication is multi-directional. So we're going to move on now, and I'm going to hand it over to my colleague, Sue.
We love this quote from Maya Angelou. We think that it sums up really our ultimate goal of that person-centered or working with healthcare model that Elaine was talking about. Her quote is that I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And as care providers, we strive to make all those we service feel not just heard, but respected, cared for, and valued, and really elevating their voices from our side. With this collaborative and positive relationship, meaningful goals can then be established and achieved for both the clinician and the client. So Ms. Angelo, she eloquently summed up our goal, but our big question is, how do you get there? Next slide, please. We propose fostering mindfulness of the 3 Ps on our path to elevating voices of all those that we serve. The first is partnership. Unlike the traditional medical model where the patient is a passive recipient of medical interventions, fostering partnership and rapport in that partnership between provider and patient is key. There was a wonderful article, and if you want the reference, I can get it for you, but it was in the 2021 Journal of the Royal College of Physicians, and it was authored by a first-year physician who was basically lamenting the fact that he missed out on learning how to form a meaningful doctor-patient relationship because of the pandemic. That portion of his experience was limited. I definitely want to find this guy because he really sounds like an amazingly self-aware young man, recognizing not just the academic and the scientific part of his job as a physician, but the more importance of achieving an effective interpersonal skills and relationship with his patients. He goes on to define rapport as a harmonious relationship that relates to collaboration and parity between patient and healthcare provider. Again, what a forward-looking young man. He notes that effective rapport has been shown to improve patient compliance with treatment, clinical outcomes, and patient satisfaction. Really a win-win for the healthcare provider and the patient. The second P, proficiency. The provider has the expertise in disease process. And unfortunately, if the importance of partnership is not recognized, the awareness of proficiency stops there. Many healthcare providers can have the attitude of, I've gone to school for a long time, I've studied really hard, perhaps paid lots of money, and I know best. You just need to listen to me. And certainly, as Elaine described, when I entered the healthcare field, that medical model was still really ruling. Of course, with that attitude, the provider is missing half of the expertise. That is the patient's expertise regarding his or her own body. Now I think I value the proficiency of my patients and their families, but I have to tell you this story that gave me a great lesson. There was this young woman who was actually a police officer injured on the job. She suffered a severe brain injury. And know that in recovery from brain injury, there's a phase where the survivor is often very confused and agitated. And this is really the phase that this woman was in. During this phase, the patient will struggle, particularly in environments that are overstimulating, and the commotion may result in agitation, screaming, and other behavioral disturbances. This woman's family and her friends were super supportive, and they had decided to hold a fundraising dinner, a spaghetti dinner up in Erie for her, and asked the brain injury team if it would be okay to take her to the fundraiser. They felt strongly that the patient would benefit from attending the fundraiser and feeling the support of her family and the love from her family and friends. I can tell you, every single person on the rehab team thought it was the worst idea ever. Everything in the literature, every book I've ever read would confirm that it is the worst idea ever to take an individual at that level of recovery into such an environment. But the family insisted. And so the team rallied. We provided the training, the equipment, the medications, including a few prayers, and everything that she would need to go on this outing with her family. And they did it. And it was amazing. And it was a turning point for this woman's recovery. Definitely a lesson learned for me and our team that we don't always know best. Next slide, if you would, please. The third P is perspective. And this patient's family really had a different perspective on what this patient needed, despite all of our research and literature and knowledge about brain injury that every individual has. This cartoon on the left, do you see what I see? Everybody is looking at the same elephant, but seeing a much different perspective, or having a much different perspective. I'm not going to take the time to do the example on the right, but if you haven't seen it before, it's kind of fun that it shows on the screen the words green needle and brainstorm, and you can hear kind of a creepy voice in the background. And the game is, if you look at green needle, you will hear green needle, and if you look at brainstorm, you will hear brainstorm. Doesn't always work for me, so go there after this talk and see if it works for you. Similar situations with the woman in the purple dress versus the red dress, and what you see. The point being that we all have different perspectives, and that's okay, as long as we as healthcare providers recognize that our patients and families will have different perspectives, and that these perspectives should be heard and certainly should be valued. And we don't always know best. So we need to be mindful of our 3 Ps: partnership, proficiency of both provider and the patient, and perspective, again, of both the provider and the patient. Got it. Great. But these are some pretty abstract thoughts. And anybody who knows me, and I think this is a common characteristic of physical therapists, we're pretty concrete. We need something that we can hold on to help us foster these ideals for patient relationships. Next slide, please. As we mentioned a few times, Elaine and I specialize in assisting people who've suffered moderate to severe brain injuries. Again, as described earlier, brain injuries can result in significant behavioral, cognitive, and physical deficits that can be challenging to manage. When our brain injury program was moved to our current location, many staff members at this hospital were anxious, maybe even fearful of working with clients who had suffered such catastrophic injuries that we were used to working with. And although we provided much education, the very subtle, concrete skills that I think Elaine and I had developed over the years of working with this population were hard for us to recognize, and certainly difficult for us to articulate to the staff members who were new to working with individuals who had suffered injuries. Staff would say things like, "Wow, he listens to you? I can't get him to do anything. I can't believe he's even talking to you. He just screams at me." Or, "How did you get him to do that?" Privately, Elaine and I would say to each other, I think that the secret is just be nice. And that's where this mnemonic grew out of. And I was happy to see Sabra's comment about kindness, that there is never enough kindness. But our mnemonic of be nice really, I think, captures some of the concrete things that we can do in our practice and our interactions to foster that working relationship with our clients. Let's run through each letter. B is for body language. A study by Merabin and Ferris reported that impactful communication was 7% verbal and 93% nonverbal. That's a shocker to me. And of that nonverbal, the primary component was based on body language. I think that this was really the problem with our staff, because our staff, again, were not used to working with clients with such catastrophic injuries, and they were tense, they were anxious, and that anxiety came through in their interactions with our patients and made the entire interaction tense. Another example of the impact of body language can be seen in a study where there was a set script of information that was provided to patients in a hospital. The exact information was provided by the same staff member to different patients. The only difference in the administration of the information was that in half of the cases, the staff member stood, and in the other half of the cases, the staff member sat while providing the scripted information. Then the patients were asked to rank how knowledgeable the staff member was, how compassionate the staff member was, and how much time the staff member spent with them. Across the board, the patients who received the information from a staff member who was seated ranked higher in all categories. So heck, if I can sit down and be smarter, I'm all about it. But we know that body language matters. And in fact, it matters a lot. Holding yourself in a relaxed, open posture, respecting your client's personal space, getting at eye level, and when possible, sitting are simple ways, simple concrete things we can do to build that rapport. As the next letter in our mnemonic indicates, maintaining good eye contact conveys not only that you're listening and attentive, but is certainly one of the most important forms of body language. We all know that this can be challenging to balance, especially when we're taking notes or entering our documentation on our computer. But appropriate eye contact is essential if you really want to establish that strong and effective working relationship. Next is nurture. The definition of nurture is to care for and encourage growth. This is really focused on hearing your client's needs and their goals and supporting them on their path toward their goals. Again, I think this is a change. Early on, I would tell individuals that my goal for you is that we'll walk up 150 feet by the end of the week. And that client might say to me, my house is small. I only need to walk 50 feet. And I said, well, that's okay, because Medicare says we need to walk 150 feet. And certainly realizing that it is not about my goals, it is about that client's goals. I stands for interest. Along with appropriate eye contact, we know that this communicates listening and interest. But further interest can be shown by repeating what you hear and asking questions to get to deeper understanding. I mentioned the article by the first year physician, and he really investigated what he could do to build that relationship. And after much trial and error, he settled in on simply discussing what the client's current or past occupation or vocation or interests were, served to communicate and build a connection in really a non-threatening manner. C is for that connection. And as human beings, I think we have certainly many more similarities than differences. Also, as human beings, we feel comfort when we can find those similarities and connect over them. It often surprises me how realizing a connection as random as being from the same area or liking the same music or rooting for the same football team can create an instant connection with your patient and instantly brings a familiarity or comfort to the relationship. But you can't connect if you don't seek those connections. So recognizing the importance of those connections. Finally, empathy. Empathy is the ability to understand and share feelings of another. This is different from sympathy, which is understanding that someone else is suffering. And although important, Dr. Brené Brown describes that empathy drives connection and sympathy drives disconnection. I don't think we have time for it now, but Dr. Brené has a wonderful TED Talk that addresses this. If you haven't seen it, it really is worth the few minutes to watch, obviously on YouTube. But she clearly defines the difference between empathy and sympathy, and certainly supports the use of empathy in healthcare and creating that connection with our clients. So concrete, that's what I like. Things that we can do to elevate those we serve. Just be nice. Think about your body language, especially your eye contact. Nurture goal development and growth. Show genuine interest and empathy to develop strong connections with your clients. Next slide, please. I find myself continually saying client or patient, but really all these concepts are key to any strong working relationship. In rehab, and often much of healthcare, the patient's family or caregivers are also important members of the healthcare team. In recognition of this, we recently started a program called the STEPS program for caregivers, for all of our caregivers in rehab. And again, another mnemonic here. But you can see that the letters of STEPS stand for providing support for the family who is certainly going through a trauma with the recovery or the injury and the recovery of their family member, providing hands-on training, providing written and verbal education to that family, providing them with proper planning and preparing for discharge, and certainly giving them the tools that will hopefully lead to success after discharge from inpatient rehab. So in addition to elevating the voices of people with disabilities, we also recognize that sometimes their voice is that of their caregivers, and trying to provide support to the caregivers as well. Next slide, please.
Okay, so I want to just jump back in here, and as Sue said, when our patients and our families are part of the team, then their voice matters. And so I would encourage all of us, and Sue and I encourage each other daily, to consider what is going on in the hearts and the minds of our patients and our coworkers and our families. And so it's important to ask questions, to hear experiences, and really to listen to the answers, because I think it's easy in healthcare, from our perspective, to ask the question, but more difficult to really hear the answers and do something about the answers. As many of the folks in the beginning of this Lunch and Learn stated, the value of lived experiences are so important. And it's easy for me to say, oh, you must be feeling this, or this must be terrible, or this must be, you know, comforting to you or frustrating to you. But until we ask our patients, we don't really know. And so asking and gaining their perspective and gaining an understanding for ourselves on what someone is experiencing is just really vital. We put this in here, and it is not a definite list. You can ask your own questions, but I do encourage you to those people who you experience with, who you do life with, to ask, what is it with healthcare that has made you feel angry, sad, or frustrated? And also on a positive side, what has made you feel happy, comforted, or heard? Because I think by asking the negative and the positive, we can gain a lot of information on what we're doing right and what we're doing wrong, and how best to really capture that and then proceed to do something about it. Next slide. So in conclusion, just really to stress, we try very hard to make sure that everybody has a place at the table. And I think by inviting people to your table, whether it be an actual table or a figurative table, I think it gives voice, it gives a space, it gives time. And so just really including everyone who is born deserves a place and a time and an ear to hear. So people should feel heard, they should feel safe, they should feel respected and valued. And if we're not doing that as clinicians, then we're doing something wrong. Communication should definitely be bi-directional or multi-directional. It shouldn't be just one clinician or someone supposing they have the expertise dictating what is happening. In healthcare, it really should be patient. The patient should have a voice in what their care is. And then it's nice to be nice. So ask, listen, and be open to opportunities for improvement. And I think, go ahead, next slide. I think that ends our presentation. So I'll turn it back over to Rhonda.
Thank you. Elaine and Susan, thank you so much for sharing so many stories and research references and concrete practices to share with us a snapshot of how you operationalize your mission and vision. Wow. That last slide you had up, questions we'd like to invite now. Use the chat if you want to make comments, like I see Sally Joe just offered in the chat. Participants, you can either throw comments or questions there. You're welcome to share additional practices that you're familiar with, or jump in and open up mics or use the raise hand feature, any way at all in terms of inviting questions.
Thanks, Rhonda. I wanted to add something to the previous presentation about lived experience related to, I mentioned the health resume, because we're actually working to operationalize that lived experience from families. We had a happy accident. I know we had some little tech challenges at the beginning. We had a tech challenge that turned into a wonderful teaching tool. We have something we call, we being Jefferson has something called the health resume, which we're in the process of developing. And we had it all planned out, and we were going to pilot it in a particular area in the health system. And somehow and that was like 300 people. Well, somehow I got out to 3,000 people. And it asks for your lived experience, some of the very questions that were just asked. What do you like about this? What don't you like about this? So that it is bi-directional. So, if you have a healthcare portal and all of the information is in it from your medical providers, the health resume provides a way that we're working to integrate with the healthcare portal with information from the person, from the self-advocate, from the person with whatever they have going on, and the caregiver, so they can say that it would be helpful to have that first appointment in the morning or the last appointment in the afternoon. Or they can say, don't like it when XYZ happens, love it when XYZ happens. Now, we can't always do absolutely everything, but it provides information to make sure that those lived experiences are captured and listened to and looked at directly by the medical providers in the charts that they're always looking at. So we're working to operationalize that.
This is Rhonda. Oh, that's exciting. So it's something that's then shared across providers that would be in that same network.
That's the plan, but as you well know, it takes a number of steps to make that happen. And I see Trieste's question in the chat. It's not yet available to others, but the plan is that it will be.
Other questions, comments?
Hey, Rhonda, I'm going to jump in. This is Sally Joe. I did put it in the chat, but I'll fire it off. Thank you both, all of yins. Yins go Pittsburgh. So thank you, Elaine, Sue. Thank you, Sabra. Thank you for the work you do my question, and I'll just fire it off, I put it in the chat, are any suggestions that you have and how to create right from the get-go the environment, that welcoming space, that good vibe that really sets the stage for persons to come in and claim the power that, you know what, I'm the second needed perspective in this healthcare encounter. How do we establish that right out of the gate? Because a lot of times, I mean, the folks with whom I work and share life with, not high on their list is wanting to go to the provider, and they go in already, for all that Yins had shared, already intimidated and kind of like, well, whatever they say I'm going to do, I'm really not going to engage. So in my long-winded, albeit charming long-winded way, suggestions on how we can create that space right from the get-go.
Yeah, I'll put my mom hat on. I'll say it even started not only in the hospital setting, but also in the education setting. I park a picture of Brandon in the middle of the table so that people know that we're talking about the same guy. And then when he was able to participate, he would be there. You know, so there's that. There's also working to take the time to build the relationships. And I know that's not always easy. I know that there's time, and, an appointment might be X amount of time. That's why we're looking to make changes. And we're pretty ambitious. Wendy Ross, who's our center director, has been accused of trying to boil the ocean, but we're trying to shift the system to provide the time. Like, if more time is necessary, take the time to build those relationships. Take the time to work with the nurse practitioner, if the doctor is busy. And it also requires a shift from the caregivers, the parents, the individual's perspective to ask those questions. Right. So I have a way of parking myself at the front desk and asking nicely, pleasantly, but I'm kind of not leaving until I get an answer. That's one way. And again, I don't want it to sound like that's confrontational, because I don't mean it to be, but building those relationships so that there is an expectation from the providers that you're going to be asking. I hope that's helpful.
It is, and I'm going to just run this ball a little bit further, unlike my Steelers last night, but I digress. How exactly, though, how close are we to setting up the format in medical schools and already establishing the model that, Sabra, what you're doing, I think is great, but that stuff isn't even needed anymore, because we're getting closer to establishing more that patient-centered model. Are we close to that? Are we close to totally living Be Nice and that just be the get-go? And I know that, and my folks know that, before they even enter the appointment, we've created these spaces. Are we getting closer to that reality? Anyone, Elaine, Sue, anybody on that perspective?
I'll just say we're pedaling as fast as we can.
Amen.
Yeah, and I'll jump in and say, I do think, boy, it's a work in progress. And I think, there's been a lot of movement forward in individual settings and clinics, but I do think we got a long way to go before we get where we need to get. And to go back to your first statement, I think probably one of the most valuable things, which was rather intimidating early on in my career, and now I love it and seek it out in patients, is Sabra, as you said, especially with an advocate for a patient, or the patient, if they're able, comes at me with a list of, here's my goals. And I remember the first person who came at me with a piece of paper and said, here, fix this. And it's very daunting and very intimidating, but over the years I've come to really appreciate that, because it really does put it all out there on the table so that and it gives the voice to the patient to start, and then we move forward from there. So I do think we have a long way to go. I think, as I speak as a therapist, and I think as therapy schools, the ones I'm involved with and the students that I work with, I think there is a push toward that, maybe more than certainly in the past. But I agree, we have a long way to go.
This is Rhonda. Let me pull forward one more question and then we'll need to close today. There's a question for you, Sabra, in the chat from Kathy. I'll invite her forward in a moment. One of the things that your colleagues, Mary and Karen, really helped the task force think about, and it is embedded in recommendation number 1 that Emma introduced, is that elevating the voices of people with disabilities is not only about their individual health care, it is about systems. It is about practices. It is about systems design. Kathy, bring your question forward.
So yeah, Sabra, I was just curious if you could share some of the ways that Jefferson has included your voice and people with disabilities within the system so that the whole system is designed in a way that's thinking about these needs from the perspective of people with disabilities. Thank you.
Sure, you're welcome. To the previous comment, we do have a long way to go. I don't want to imply that it's all perfect now, because we certainly are working toward those as goals. By example, Karen made a point and suggested that I mention that there's a waiting list for services at Fab Center at the Navy Yard. So even if someone's here and interested, yet they're at capacity, and you would have to wait, probably 6 to 9 months to be able to receive those services. So we're not quite there yet. But on the other hand, we are creating not only coursework, as I mentioned, with the medical school to broaden medical students' perspectives about providing services to individuals, and our focus is neurodiversity and autism. We've developed a coursework in fashion. For instance, yesterday we did critiques around fashion design for people who travel in wheelchairs or people who are blind or visually impaired. We have an immersive art, and all of these have individuals with disabilities as either a part of the design piece or a part of teaching the class. Right. So every possible place where we can have a person who's neurodiverse, on the spectrum, has a disability, be a part of it, because to your point, it's not just medical. We live our lives. Like I said, Brandon takes his body everywhere he goes. So we want to make sure, to the extent that we can, and build the models so that they can be replicated. But it takes more than us. It takes everyone having that inclusive, that belonging mindset of saying, hey, is there a different way to do a particular thing that includes as many people as possible in ways that are significant to their lives? So we try to be practical. We worked with Parks and Rec. We're doing visual stories for sport events in Philadelphia. Parks and Rec has an annual wheelchair basketball tournament. We're doing Safety on the Spectrum, which is a collaborative between families who have family members and the actual self-advocates, collaborating with first responders, police officers, and fire to make sure that they recognize some of the challenges before the bad thing happens. Right. So we're looking at all angles, because we want people to be able to live their lives as independently as possible. We're looking at housing, the built environment, what it means to have someone live as independently as they are able. So with that being said, it's not perfect. We're not there yet, but we're looking to impact systemic changes. And I'll give one more quick example in terms of systemic change. We ran the numbers, 60+ million families when at the height of the pandemic, and actually made some changes. Remember when certain people couldn't get the vaccine because they didn't fit in certain categories? We did the research to show that our folks with disabilities and neurodiverse concerns needed to be in that first grouping to get the vaccine, because unfortunately they were dying at higher numbers and not being admitted to the ER as fast as others. So we try to be very practical in the work and the research and the advocacy that we do. Hope that answers your question. Thank you.
So many powerful examples of something you said earlier. If you're not doing disability as a part of diversity, you're not doing
it right. That's exactly right.
We'll go to Emma Nolan, our host from the ARC of Pennsylvania, to thank our speakers and close today's webinar.
Yeah, just reiterating what Rhonda just said, thank you so much to our wonderful panelists today. We really appreciate you guys taking the time and presenting and teaching and sharing your experiences with all of us. And thank you to all of our participants today who have signed up. I hope this was as informational and informative for you guys as it was for us on the ARC side. We have 2 more lunch and learns being offered on December 12th and December 19th. December 12th is all about accessible and alternative healthcare delivery. We have a doctor or a dentist from Penn Dental who is going to be presenting, as well as a physician from Station MD, which is a telehealth service for people with IDD. And then on the 19th, we have disability and inclusive healthcare systems. And so far we have the physician from Wood Services in Eastern Pennsylvania. So we are really looking forward to both of these, and we hope that you guys can join us for these as well. But if not, I hope you all have a, one more slide. Sorry, I forgot about this one. Just to plug 2 summits that are going to take place next year. The ARC of Pennsylvania is hosting a Disability Health Action Summit at the Sheraton Hotel in Harrisburg on March 6th, 2024. We have recently put out the save the date and are confirming all of our speakers for that. The registration is forthcoming, and we will make sure to share it with you all. There's another summit happening on April 4th and 5th of 2024 from the Pennsylvania Department of Health, Office of Health Equity. And that is centered around a lot of different areas in health equity, one being disability. So both of these summits are going to be really informative, and I definitely urge you all to sign up for those and register when they're available. But if we don't see you at the next 2 lunch and learns, I hope everyone has a healthy and safe holiday season. And thank you again for joining us today.